Hello, my name is Bridget. Welcome to this class. Last class we talked about the motor symptoms of Parkinson disease. Today we're going to explore the non-motor symptoms of Parkinson disease. We hope you enjoy it and, please, pause the video as many times you need. Well, it is known that the pathological changes in Parkinson's disease involves the dysfunction of non-dopaminergic cells. And this dysfunction is thought to play a major role in the development of the non-motor symptoms. According to Brock et al., there is a 6-stages pathological process beginning in specific sites. As you can see in this figure. Let's zoom in, so you can better visualize it. Better now. So, Brock stage 1 denotes degeneration of the olfactory bulb and the anterior olfactory nucleus, which can clinically manifest as olfactory dysfunction. Brock stage 2 characterizes progression of the pathological process to the lower brainstem. These areas, implicated in the preclinical stages 1 and 2 of Parkinson's disease, are also thought to be key areas that mediate non-motor symptoms, such as olfaction, sleep homeostasis, and other autonomic characteristics, such as sleep-wake cycle-related pathway. This pathway are represented by the Raphe nucleus, responsible for the release of serotonin, the locus coeruleus, responsible for the release of norepinephrine, and finally the pedunculopontine nucleus. The Brock stages 3 and 4, when the neurodegenerative process has finally affected the substantia nigra, and other deep nuclei of the midbrain and the forebrain. Please notice that this stage is when Parkinson's disease crosses the threshold from a premotor disorder to a motor disorder and is clinically diagnosed. The final 2 stages, Brock stages 5 and 6, correlate with the presence of Lewy bodies in limbic structures and mature neocortex. At this point patients may have neuropsychiatric symptoms, such as depression, cognitive impairment, and visual hallucinations. So, as you can see in this figure of Parkinson's disease progression, in general some non-motor symptoms tend to appear prior to the motor symptoms, hence prior to the diagnosis itself. Now, after understand about the physiopathology of the non-motor symptoms in Parkinson's disease, we are going to discuss a little bit about each one of those. Let's go. I'm here in a patient's bedroom to talk about the sleep disturbances. Let's begin with the nocturnal non-motor symptoms. They usually start early in the disease course, probably related to pathological degeneration of central sleep regulation centers in the brainstem and thalamocortical pathways, as well as abnormalities in primary sleep architecture. Some non-motor symptoms have a secondary effect on the quality of sleep, such as nocturia, that causes the patient to wake up several times during the night to urinate, causing bedwetting if the patient is too rigid to get out of bed, or restless leg syndrome causing frequent arousal. Now, about the REM sleep behavior disorder, observed in Parkinson disease patients. It occurs in about a third of patients with Parkinson's disease, and represents a parasomnia characterized by loss of the normal skeletal muscle atonia during REM sleep, thus, enabling patients to physically enact their dreams, which can often be vivid or unpleasant. We can also observe vocalizations like talking, shouting or vocal threats, and abnormal movements like arm or leg jerks, falling out of bed, or violent assaults. REM sleep behavior disorder appears prior to motor symptoms in 40% of the cases, and, as we saw previously, it is related to a degeneration of lower brainstem nuclei, including the pedunculopontine and subcoeruleal nucleus, that are characteristics consistent with Brock stages 1 and 2. Now, let's talk about the excessive daytime sleepiness. Excessive daytime sleepiness and involuntary dozing affects up to 50% of patients with Parkinson's disease and could be a preclinical marker. It is an important symptom, because it can substantially affect quality of life in Parkinson's disease. A combination of the disease process, the effect of nocturnal sleep disruption, and anti-Parkinsonian drugs is probably causative. And, in some patients, excessive daytime sleepiness has been linked to the development of sudden onset sleep, and an abnormal period of sleep latency in 30% of the patients with Parkinson's disease. Now, follow me to discuss a little bit about the neuropsychiatric disorders related to Parkinson disease. Now, in our patient living room, we are going to start talking about depression related to Parkinson disease. Depending on the criteria used, depression can affect up to 10 to 45% of patients with Parkinson's disease. Studies have suggested that symptoms of depression can precede the development of Parkinson's disease. Depression in Parkinson's disease could, in part, be the result of damage to serotonergic as well as limbic noradrenergic and dopaminergic neurotransmission. Let's talk about anxiety and apathy. Anxiety disorders are common in Parkinson's disease and can also be a preclinical risk factor. Anxiety can present as panic attacks, phobias, or generalized anxiety disorder, and can be related to drug-induced motor fluctuations in Parkinson's disease. Occasionally anxiety syndromes and mania have been reported as a side effect of dopamine agonist treatment and high-dose levodopa treatment. About apathy, it has now been established as a distinctive symptom of Parkinson's disease, independent of depression, somnolence, and fatigue. It is known that patients with the disease have higher levels of apathy than do equally disabled patients with osteoarthritis, which indicates a neurodegenerative contribution. In Parkinson's disease, functional imaging studies have suggested decreased reward processing in the brain. Additionally, testosterone deficiency has been implicated in the causation of apathy, lack of energy, sexual dysfunction, and depression. The features of apathy in the disease respond only slightly to dopaminergic drugs, possibly indicating more extensive contributions from other neurotransmitter pathways. Our next neuropsychiatric symptom are the psychosis and visual hallucinations. Psychotic symptoms strongly correlate with the need for nursing home placement and with mortality. Although visual hallucinations are commonly viewed as a side effect of treatment for Parkinson's disease, neuronal degeneration of the pedunculopontine nucleus, locus coeruleus, and the dopaminergic raphe nuclei might be causative. As psychotic symptoms, we can cite visual hallucinations, delusions, paranoid ideation, and delirium, that last one becoming more frequent as the disease progresses. The last neuropsychiatric symptom that we will discuss today is the cognitive impairment. It occurs in up to 40% of people with Parkinson's disease, a rate of 6 times higher than that in healthy individuals. Dementia appears as the disease progresses. It is progressive and clinically characterized by a dysexecutive syndrome, with impairment of visuospatial abilities and memory on a background of loss in response to dopaminergic drugs including levodopa. As we saw previously, the degeneration of nigral cells is implicated, and although presence of cortical and subcortical Lewy bodies is also likely to be causative. In the sequence, we are going to talk about dysautonomia. Let's go. Here in the backyard, we are going to discuss that important point about non-motor symptoms, that is, the dysautonomia. Dysautonomia is a key characteristic of multiple system atrophy but occurs with varying severity in Parkinson's disease. As we saw before, the pathophysiology is complex and includes degeneration and dysfunction of the nuclei mediating autonomic functions such as the dorsal vagal nucleus, nucleus ambiguus, and other medullary centers. Among the autonomic symptoms, there is orthostatic dizziness, constipation, bladder dysfunction, erectile dysfunction, and hyperhidrosis. Let's discuss it point by point. Firstly, about constipation. It is one of the commonest non-motor symptoms of Parkinson's disease and can precede development of the disease. Although there is severe loss of both central and colonic dopaminergic neurons in Parkinson's disease, constipation does not respond well to dopaminergic treatment, suggesting that non-dopaminergic mechanisms could also be implicated. Another important affection in Parkinson's disease is sexual dysfunction. It could be part of the spectrum of dysautonomia, and both reduced and abnormally increased sex drive is reported. In addition, it is known that testosterone deficiency is also implicated. However, aberrant sexual behavior and drive including hypersexuality form part of the dopamine dysregulation syndrome, which is linked to dopaminergic drug treatment in susceptible patients. The last dysautonomia symptom that we will highlight is pain. It is common in Parkinson's disease and can have both primary or secondary causes. Pain may be related to motor fluctuations, early morning dystonia, or secondary causes, such as musculoskeletal pain. A deep visceral pain is also described in the disease, and, rarely, this can represent development of retroperitoneal fibrosis related to use of some dopamine agonists. In addition, oral pain, burning mouth syndrome, and genital pain could occur, and need to be recognized. Lastly, let's talk about olfaction. Olfactory dysfunction, which eventually affects up to 90% of patients with Parkinson's disease, is a potential preclinical marker of motor symptoms. Consisting of early degeneration of extraneural neurons in the olfactory bulb and anterior olfactory nucleus. Some non-motor symptoms are peculiar to the wearing-off event that occurs in levodopa-treated Parkinson's disease. Non-motor symptoms such as anxiety, pain, tingling, coldness of limbs, restless legs, and unclear thinking can occur at the onset of wearing-off. A specific wearing-off patient questionnaire has been validated to aid clarification and better definition of motor and non-motor symptoms of Parkinson's disease related to wearing-off. In summary, in this class we discussed that most non-motor symptoms evolve early in the disease course, appearing prior to the motor symptoms, hence prior to the diagnosis itself. The non-motor symptoms are divided in sleep disturbances, neuropsychiatry disorders, dysautonomia, and olfaction disorders. And finally, the early recognition of non-motor symptoms is essential for the care of patients with Parkinson's disease and the importance of a multidisciplinary approach. Thank you for watching this class. Remember to answer the quiz, it will help you to memorize this content. Next class we will talk about pharmacological and surgical treatments for Parkinson's disease. See you soon.